Developmental Pediatrics at Phoenix Children's. And Diana Davis-Wilson of Hope Group and I are presenting today about a program that we developed called Early Access to Care Arizona to train okay, it's all right, I'll just look. But to train pediatricians in regional teams with AZIP providers and school providers, not just to screen young children for autism, but also to make diagnoses of autism and provide medical home care to children with autism. So we've called our talk, we'll just hold it. We've called our talk Bringing Best Practice Autism Care to Primary Care, Innovative Models to Increase Capacity and Expertise in Caring for Children with Autism. So you all know that Danny Kessler this morning presented to all of us about his history in Arizona. And when he came here in 1990, he was the second developmental pediatrician in Arizona. And when I came here in 1996, I was the third developmental pediatrician in Arizona. And so right now we still have very few developmental pediatricians, very few child psychiatrists, not enough licensed psychologists who are doing diagnosis, but also who take access and private insurance, because many of you know that a lot of the psychiatrists and psychologists take just private pay, which limits access to assessment. So, and in other states, pediatricians diagnose autism. And in other states, they don't have some of the barriers we have because Arizona legislated who was allowed to diagnose autism. And in fact, when I came to Arizona in 1996, it was only legislated that child psychiatrists and licensed psychologists could diagnose autism. And I said to Dr. Kessler, Dr. Melmed, well, hey, what did I just spend 3 years in fellowship training to do? So it took 8 years to get DDD to change policy to allow developmental pediatricians to diagnose autism. So what do we know about medical treatment of autism and why do pediatricians need training? That's what we're going to talk about. We're going to start with reminding us all that the prevalence has significantly increased. In Arizona, it's 1 in 66 children, and autism does not discriminate, so it occurs in all races, religions, ethnic backgrounds, socioeconomic groups. We know that it's 4 to 5 times more common in boys than in girls. And we know that the average age of diagnosis in Arizona is 4 years, 7 months, when in fact we all know that parents have concerns way before that. And we know that we can diagnose autism way before that. We also know that it's very costly. $3.2 million is the lifetime per capita societal cost. That's per person. And so a lot of that is because of loss of productivity and adult care and healthcare dollars and less access to medical homes. And if we can train pediatricians to provide medical home care to children with autism, we can bring down healthcare costs and help families with their children and help them coordinate care. And Diana's going to be talking about that. So this is just a quick table. There a pointer? Oh yes. Oh good. What we did is we took that, it was 1 in 64 number when we did this, and we kind of calculated the number of children with ASD that should be counted per county of the people that we were training in our first cohort of trainers of pediatrician mentees, and I'll tell you more about the training in a little bit. And so, because we had pediatricians, oops, that's not what I wanted to do. Because we had pediatricians in Casa Grande, 3 of them who were interested in training, you know, there should be 1,769 kids, birth to 18 with autism. Certainly this adds up to about a little over 28,000 children. And we know that DDD is only currently serving 5,000 was the number? Yeah, of those kids. And I work at the Indian Medical Center, so I still see kids that come from all over the state that are Native American who have never been in school, have never received a diagnosis are 6, 7, 8, 9 years old, because their parents don't think that that they would, be able to go to school. And so I just think these numbers were quite impressive. These are the numbers of practices for cohort 1 and cohort 2 that we've trained thus far. Slowly but surely, we're seeming to make a difference.
Can I ask a quick question?
Yes.
For DDD, is it just developmental pediatricians that can diagnose that they will accept, or are they also accepting psychologists and psychiatrists?
Yeah, child psychiatrists and licensed psychologists have been an acceptable diagnostician for way before I even got to Arizona.
Yeah, I just didn't know if they had changed the legislation for DDD to only accept developmental.
Oh, no. They haven't even changed the legislation. What they changed was a policy rule, an administrative rule, to allow developmental pediatricians to diagnose. Prior to that, every single diagnosis that Dr. Kessler, Dr. Melman, myself, and then Dr. Rice in Tucson was making had to go across Dr. Klain's desk, the DDD medical director at the time, because he was a child psychiatrist, and he signed off on it for us. So why do we need to identify kids with autism early? We know that it causes severe disruption for children and for their families. And a long time ago, we used to think that the recurrence risk was between 3 and 10%. We now know, thanks to Betsy Osinoff's study in 2011, they published a multi-site longitudinal study that shows that the actual recurrence risk is 18.7%, much higher. We also know that early intervention works, but we know that early intervention is not accessible to all, and if you don't have a diagnosis, you don't get the early intervention that you need. And we know that when kids get 2 years of ABA type of intensive early intervention versus 2 years of special needs preschool, the kids with the 2 years of ABA have 25 points higher on their IQ, are more included with typical peers, and have better adaptive functioning. Oops, there we have it. Sorry, I jumped ahead of myself. But moving forward, our primary care provider colleagues, our pediatricians, our family practice docs are going to be called on more and more to identify these kids and provide the care that these children and their families need. So this is just some data that I pulled together from Phoenix Children's from January to August of 2015. And the table over here, so when I point to that, it doesn't go over here either, does it? Sorry about that. The table shows the clinic visits, and we broke them up between Maricopa County and other counties, and then we broke it up by autism diagnosis, ADHD, Down syndrome, Fragile X, congenital heart disease, developmental delay. But the 2,069 are the kids in those 7 months who were referred and not yet ever scheduled, because we don't have capacity. And so those kids don't have access to diagnosis and to care. And we know that children with ASD need multiple subspecialties, stay in the hospital longer, need coordinated care. And so this was some of the beginning information that I obtained to be able to write a grant to get funding so we could do a better job. We know that the current detection rates of developmental disorders are lower than the actual prevalence. We know that in 2001, the American Academy of Pediatrics published a policy statement to outline the need for ongoing developmental screening and surveillance. Screening means using a standardized tool, surveillance means monitoring the milestones. So the AAP puts out this policy statement and you think, oh good, pediatricians will do a better job. Well, in fact, in 2005, 4 years later, they looked at this and found that these detection rates of developmental disorders were still lower than the actual prevalence. And without the use of standardized screening tests, pediatricians, on average, miss 70% of kids with developmental and behavioral delays prior to kindergarten. So 70% of kids, without using standardized tests, are not being identified and not getting early intervention. So in 2006, they published another policy statement with an algorithm to follow so that pediatricians would use standardized developmental screening tests at 9 months, 18 months, 24 or 30 months. And with that goes the M.Ed, the autism screen at 18 months and 24 months. We all know that the care of the child with autism is 24/7, 52 weeks a year. So I was supposed to ask this at the beginning, so I apologize. So raise your hand if you're a parent. Well, we're all parents. Raise your hand if you're a parent. Many of us are parents. If you're a parent of a child with ASD. And raise your hand if you're a therapist. And an educator. And a medical provider. Anybody? Yay. Thank you for coming. So a lot of our kids need very little sleep, right? I mean, some studies show up to 80% of kids with autism have sleep disorders. Our kids have disruptive and aggressive behaviors, and sometimes that's because they have an ear infection, or because their stomach hurts, or because they're constipated. We know that they often have food selectivity, so they may not be getting the vitamins, minerals, and nutrition that they need. And it also may be contributing to their constipation. If all you're eating is milk and Lorna Doone cookies, you're probably constipated. They have self-injurious behaviors, and sometimes that's a way of communicating that I hurt. And they are often flight risks, right? So our families panic and have to put their house on lockdown because if the child gets out, they may flee and run out. And I actually have a patient who is very smart, and he learned how to get the deadbolt. He found the key to get out to the garage and knew how to turn the car on and got on a ladder and pushed the button open to open the garage door and started the car.
Wow.
And he was 5, and that's very dangerous. And we also know that kids with autism are at risk for other diseases. And so I put this up here, and this one part of our training is training pediatricians about the medical conditions. Up to 70% of our kids have GI problems. Up to 39% can have seizures. And they have common childhood illnesses that need to be addressed and need to be thought of when the child is having new self-stimulatory, new self-injurious behaviors, more sleep problems. And they have not so common illnesses. I mean, just in the last 5 years, I've diagnosed, the developmental pediatrician, has diagnosed diabetes, juvenile rheumatoid arthritis, and leukemia. Because they were new behavior problems. So I'm just putting up this table. There are countless interventions that pediatricians have to address all the time. Up to 90% of our families who have kids with autism try a complementary and alternative treatment. But if the pediatrician doesn't know to ask, the families don't often reveal that. And the PCPs need our help, right? Most PCPs want to do a good job. On average, a PCP will take care of at least 10 children with autism. And children with autism come to their PCP more frequently because they have increased rates of comorbid medical conditions, more mental health problems, more behavioral concerns, and developmental delays. But if the PCP isn't trained to recognize or help guide the family or treat these things, then it makes it very difficult for them to be a medical home. And in fact, this morning, because I wasn't being mindful, I was looking at my email and other articles that I was reading, and there was an article published in just May of this year by Megan Chudy et al. In Pediatrics, Barriers to Care Coordination and Medical Home Implementation. So the pediatrician were surveyed and perceived a lot of barriers to providing a medical home, and a huge part of it was lack of time, lack of sufficient personnel to lead the multidisciplinary team, to develop the care plans, and connecting with support services, and lack of insurance, both Medicaid and private, payment for that time. Most pediatricians have to see more and more, up to 40 patients in a day, to be able to keep the lights on. And just in case anybody wonders, pediatricians, for the same billing code that an internal medicine doctor, an adult doctor might bill, if the bill is $100, the adult doctor generally gets reimbursed by insurance $75. The pediatrician, same exact billing code, $35. We spend the same amount of time, we do the same thing. In fact, I think we do more because we're taking care of children. And that includes their parents then. But we get paid significantly less, probably because children don't vote. And somebody had a question. Sure.
I just was wondering,
We're going to get to that in just a
We're
second.
going to get to that.
All right.
So, thank you. A plant in the audience. So what parents say about medical providers, they say we don't get it, that we don't acknowledge parental expertise, that we don't recognize the emotional toll that ASD has on the family, the child's behavior stress parents. We don't use strategies to help with that parents feel marginalized by those who should care. And that if they, being us, medical providers, just validated parents' feelings of frustration and despair, that it would reduce the defensiveness, which is the first strategy to discussing helpful situations. So how do we fix this in Arizona? Well, we got the support of the Board of Visitors, so if any of you still want to buy a care card, the 20% discount at retailers all over Maricopa County is good till tomorrow. I just bought all my holiday presents for my office staff the other day and saved $87.
Wow.
I know, awesome, right? So they gave us a grant starting in 2015, 2016, and will continue to fund us in 2017. They're a wonderful organization. And our goals are to decrease the time between parent concern, which is often before 2 years of age, and the time of diagnosis, which unfortunately is still, the average age of diagnosis in Arizona is still 4 years, 7 months old. To train the pediatricians to provide diagnosis and comprehensive care to children with autism spectrum disorder. And these are in regional teams that we're going to describe a little bit more, with the pediatrician and early intervention staff and school personnel. And then that by training those teams and getting people to talk to each other, which Diane will talk about more, we've really worked to improve access to early intervention for the children with ASD. We also wanted to increase the accessibility of subspecialty support in rural and remote areas, so we've developed a telemedicine support network, and then increasing the number of children with ASD who get care in a medical home. So it's a 6-month learning collaborative that we're asking pediatricians to commit to, about 8 hours a month. There are two-day in-person conferences where the pediatrician gets trained in the STAT, which is a level 2 autism screener, and we have reliability testing. And then the early intervention people, the school people, and sometimes staff in the pediatrician's office is getting trained in the ADOS. And then we have a medical comorbidities conference later on. There are 2 learning modules that we require them to go through, and if anybody's interested, the CDC Act Early Learning module is 5.5 hours. It's a great 3-part learning module that for medical providers provides 5.5 hours of CME and 20 points of those Part 2 MOC points that are required. And twice monthly webinars, monthly reading material, and 2 QI projects for which the medical providers get 50 points of their Part 4 MOC points, which for those of you who don't know, we all have to do these maintenance of certification points now every 5 years and take a test every 10 years. And the QI quality improvement projects are quite difficult and cost a lot of money, but we're offering that for free. Here I got ahead of myself. They also get 29 total hours of continuing medical education. And for the AZIP and school personnel or the people in the PCP's office, we're providing an ADOS kit, which by the way costs $2,000 a kit. That's the Autism Diagnostic Observation Scale. And training and ongoing support for that. And Diana and Jessica Armendariz, our medical home specialists, do regional team site visits and support. So this is just to give you an idea. In first cohort, we trained 12 teams outside of Maricopa County. Those are all the stars in the red. And in cohort 2, we trained 10 teams in Maricopa County and 1 in Cottonwood. In cohort 3, we're going for 15 in Maricopa County and 15 outside of Maricopa County. And I think we are not quite meeting that. Part of it is because we didn't get one of the grants that I wrote. So we have, I think, 12 teams in Maricopa County and 5 or 6 teams outside Maricopa County. So the outside of Maricopa County are going to be Kingman, North Country, Chiricahua, which is Douglas, San Carlos, one other place. Do you remember?
Did we get the San Diego or New Mexico? Either one of
Oh yeah, there's the New Mexico person, but one other person in, one other place in Arizona. I apologize for not remembering. So the telemedicine support network is consisting of developmental peds, special education, gastroenterology, genetics, neurology, sleep, and psychiatry from PCH that we're offering to all the early access to care pediatricians. And I'm now going to turn this over to Diana, and she's going to talk to you about a medical home. So thank you for the plants in the audience.
That's perfect. She will be back. The medical home is a concept that came out about 20 years ago. It's not new, but it's newer to us. And one of the things that we recognize as a nation is that we have been dead set on this fee-for-service model. And what that fee-for-service model has done is it has created this need for us to have business and medicine combined. Because you can't run a business without being reimbursed, and you can't get reimbursed without running the business. So it's this kind of vicious cycle. And with the fee-for-service, what has happened over time is the healthcare funders have decided what we can get paid for and what we can't get paid for. And in order for us to be able to provide services, we have to match our services to that which has a bill code or has some sort of reimbursement attached, because the margins of profit are so slim, especially with access providers, and not access for Arizona by itself, but Medicare in general. The margins are so slim that we rely on every single hour being accounted for. Well, this notion of integrated healthcare and this notion of needing to go to a value-based system brought about this research again of why are we only paying for the hour for hour that we decide to pay for? Why aren't we paying for positive outcomes? And so to get positive outcomes, it goes back into the collaboration and the need for us to all be working together. And it goes back into going to where the parents are primarily going to have their source of support. And that's where the medical home model came in. So the medical home is not really a place. It's an idea, it's a concept. It is giving the families the care that they need in the place that's best appropriate to give that care. And so some of the concepts of what we actually start looking at in a medical home is who leads it, how do we coordinate that communication, how do we make sure that somebody is monitoring the progress of the children. In fact, I was presenting for AZIP last week and someone asked me, does someone really need to see a developmental pediatrician every 6 months? And I said, yes. Somebody really needs to be holding the child's progress accounted for. We have to be following that these children are making progress. And there has to be a team leader to do that. And so in the medical home, this concept, this attitude of care is really being something that's pushed to primary care physicians as a means of accessing additional funding. So if you can provide care that's outcome-based, that's family-centered, that's not just specific to the one fee-for-service that you're able to do, then we can provide better levels of care for the individuals. All right, so family-centered care, and I think that Dr. Kessler had some really great slides on this. I think that, thank you. I think that we've tried as a state to say we're a family-centered state, but I don't think that we've hit that mark as to what its true definition is. So when we're looking at family-centered care, we're looking at, again, the notion that we are taking into account the family's feelings, interests, thoughts. Now, it's hard, we're a bunch of behavior analysts, I get it, but it's so pertinent to the work that we do, because if we aren't able to have the families accessing care in a single spot, whether it be that we're coordinating in that spot and helping the families navigate the system or what have you, then what ends up happening is we have a lower satisfaction rate amongst parents, and there is research out there to support that lower satisfaction in care, that overly stressed parent, the overwhelmed parent, will lead to lack of buy-in, lack of progress in our treatment. So it's extremely important that we consider the family-centered care. So other aspects of medical home care that there's been research around is improved safety. So we know that getting in to see a developmental pediatrician can be difficult. They can't just schedule you next week, but many pediatricians can. So we've been able to see that if you can get in for significant concerns, that we can actually improve the safety of the members and as well as the families. We see a decreased cost of care. Specialty providers cost, not just cost the insurance companies, but it costs the families in having to wait, having to drive miles upon miles or hours, having to get hotel rooms to see these specialty providers. And so the idea of the medical home and everything being housed in the pediatrician would take away some of the care costs that go both into the health insurance companies, but also the family's cost. And something else to think about in cost, when we start talking about population health, which is primarily where our Medicaid funders are looking, like they want to know how we can address everybody with what little bit of money we have. When you start looking at the work that we do and its significance in preventing disease in children as they age, and we don't usually think about it. We're thinking about, oh, they've got autism and we're going to work on these skills and we're going to get them interacting with their peers. What about the increased risk, and it's about 32% of an increase in the child having obesity by the time they're 14. Food selectivity looks a lot different when you start looking at the healthcare cost that's going to be associated with that child if we are unable to do effective interventions. Now, we know we have effective interventions, but these are the perspectives that we have to then paint to the funders as far as saying, hey, look, this is how we are going to decrease costs to your system. This treatment isn't just about getting the kids to play with their friends. This treatment is a medically necessary service that will reduce healthcare costs in the future. And then we have researchers, actually in the last 10 years, an increased amount of articles published on the family satisfaction with pediatricians who are able to provide this medical home level of care. So that's been very important in family-centered care. As far as other healthcare expenditures that we see related to family-centered care, specifically if a family is not receiving respite, we know that that child has an 8% more of a chance of needing hospitalization, or we see a decrease. If we can provide respite, we decrease 8% of the likelihood that that child's going to need to be hospitalized. So again, taking care of the family, streamlining the services, making sure that we're networking appropriately, and coordinating care so that we have decreased utilization. So aspects of the medical home that become extremely challenging, and there are centers that serve as single medical homes where they provide everything in that one center. What we find in Arizona, especially with as rural as we really are outside of Maricopa County, is that it's better to have networks built and then to have kind of that hub of care coordination. So the primary care physicians are being trained right now on how to coordinate care. How do you access a behavior analyst? How do you access a speech therapist? What does this look like? What to expect from this? So that burden is not being placed on the family, similar to what we talked about this morning as well. And one of the biggest things I think through our training and our project that we have kind of stuck to is there is no one size fits all means of providing collaborative care to children with autism. And a lot of that is based on where we live. I think here in Maricopa County, we have done a really, really good job in working together. That's why many of us are here. That's why we can meet regularly, call each other on the phone. When you step out of the greater Phoenix area, this diminishes greatly. And it's influenced by funding, it's influenced by distance, it's influenced by a smaller market, so more competition. There's a lot of things that influence why these areas are unable to have collaborative care. And so one of the things that we're training in all these areas is that you have to be the one responsible for building those community networks. I can't come in and tell you how to do it. I can tell you what we did in Maricopa County for all of us to be able to work together, but I can't tell you in Casa Grande, or I can in Tucson, but in some of these other areas, I can't tell you how to work together because there's influences in there that I'm not aware of that you guys have to break down those barriers yourselves. So that's one of the things that we've been working with them on. And then building partnerships, and I touched on that this morning too, is that we can't expect that buy-in without the initial kind of pairing of the relationships with all these community partners. So if you want to be able to coordinate care effectively, you have to have an established relationship with the individuals that you're going to coordinate with, or it's going to become increasingly difficult for us to be able to ask those questions and lean on each other.
And just to tag on what Diana was talking about, it was really interesting to me to find out that the person in Prescott Valley who
came from cohort 1, Clarissa Smith, even though she's a powerhouse pediatrician, did not know the early intervention agency and did not know the school people. And now they know each other, so it facilitates access into getting the kids into the appropriate intervention. And with Casa Grande, one of the beautiful things that has happened is that even though we trained 3 pediatricians from 3 different practices down there, they all get together with their AZIP people and their school people like quarterly now with
I think they might still be monthly.
monthly with wine and cheese, but they also talk about, you know, what's going on. So they've built this incredible collaboration in Casa Grande.
And to add to that, Casa Grande is also doing multidisciplinary assessments where once a month, they also pick a Saturday where they all kind of come together and see multiple kids together at one time. So that's really neat too.
So I put up this slide. This is an article that was published recently this year in April from Rainbow Autism Diagnostic Clinic in Case Western Reserve in Cleveland, where I'm from. I'm still mourning the Indians' loss of the World Series. I just want to say that. It was very sad. I don't know if anybody watched the game, but oh my God, I was on the edge of my seat. And that stupid rain delay, if it had not happened, the Indians would be the World Series champs. They just lost their mojo. Anyway, so Beth Mishkin, Roth et al. Published this, and what they found was they looked at children diagnosed with ASD less than 48 months, and an autism, they called it an autism patient navigator, a person, a case manager, a care coordinator, call them what you will, met with the families either at the time of diagnosis or 3 months later. And the children who met with the APN at the time of diagnosis were much more successful in scheduling or completing appointments for recommended medical services, therapy.
Basic one. Actually, the autism one starts more like this. So the first button says, I can tell you about my child's diagnosis. And so after the diagnosis is received, the pediatricians are being trained to schedule another follow-up with the families. So like Danny mentioned this morning of, hey, we're going to give them handouts and bring them back in and have discussions over that handout. It's basically the same thing but electronic, where we're going to say, okay, you're going to start here and learn about the diagnosis. When you come back, we're going to have conversations about it. And there's teach back points for the families. And we move all the way through kind of what worries them after they've received the diagnosis. What are all these tests that we're being sent to? We have to go to genetics and hearing and vision, and what is all of this? What does it mean? What is an OT? What is a speech therapist? What do we know about treatment? What is effective treatment? What should we be doing? What should we know about the child's behavior? So we start to move them kind of through this map of resources. And in there, we also hyperlink the referrals like DDD, or how to call your private insurance company, or how to check if your insurance plan covers certain therapies. So all of that is carried in this app, and we are doing it in Spanish as well. And there is a paper version of it. So for a family that doesn't have access to the app platform, they could contact the Emily Center at the Phoenix Children's Hospital and get a paper version of it. So this has been a very, 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 very long project. It is almost ready to release. It will be free to the public. So in addition to the pediatricians being encouraged to utilize it, and the pediatricians are going to have the teach back points in a guide. So when the patient comes back to the pediatrician's office, they'll know what questions to ask about what services. But I think as even a service provider myself, it's going to be really nice to be able to say, hey, download this app. It's going to show you what types of services you need and what each one means. Oh, I forgot I added this. And this is what it looks like. There's teach back points for the family, so they know what to expect the pediatrician to ask for. So specific about education, I can tell you about my child's education evaluation, I can tell you about their intervention, and I can tell you who provides it, which are 3 things that I don't think pediatricians have even explored in many of these cases, even asking, what school do you go to? In fact, when we did our first round of training of pediatricians, most of the pediatricians couldn't even identify for us what districts they had. So this is a really good opportunity to start building that relationship between the pediatrician and the family so that the pediatrician can serve as that hub of information to monitor the progress so they're not having to just see specialists. So you can see just other clips of what it looks like. We have all of the different referrals. AZIP, Child Find, what is the Empowerment Scholarship. There are some family modules around AZIP that they can take video training for. So as they work through all of this, it's just opportunities for them to access resources without going to Google to figure out what's going on with their child.
Okay, so we're just going to move quickly since I know we're running short on time. Both Diana and I are long talkers. So these were just some questions that we asked prior to starting the Learning Collaborative for the first cohort. Do you refer, that's a typo. Do you refer to AZIP when you suspect developmental delays in children less than 3? And it actually is written into federal law that if you have concerns about a child under 3, that they may have developmental delays, that the medical provider has 2 business days to make a referral to the state's early intervention program. So you can see that a bunch of people were doing always, and a couple people were doing often. Okay, that's good, but it should be always. Do you get reports after referral to AZIP? So the yellow is no, and the red is yes. So that's kind of impressive that more than a third of people were not getting reports. And do you refer to the school district for special education services when you have concerns? So we had often and always. We want that to always be always, by the way. Do you use the M.Chat, which is a screening tool at well child visits? So pre-survey, these were our numbers, and the blue is 24 months, the kind of yellow-green is 18 months. It should be always at both times. The reason why we want to screen twice is because about 25% of kids with autism have the regressive form of autism, so at 18 months there may not be concerns. So post-survey, we got it to always. That one person who sometimes has had discussion with me about that, because it should be always for both. And then how would you rate your proficiency to screen children for autism? So you can see it went from expert, very proficient, to somewhat familiar, not proficient. And I will tell you that this one person right here actually did a developmental behavioral pediatric fellowship, but she's doing primary care. So she kind of skewed it. But post-survey, we had expert, very proficient, and very familiar proficient. So I feel like we made a significant impact on how pediatricians feel about their ability to screen. How do you rate your proficiency to diagnose? And you can see it was all over the board. Pre-survey, and that's what it is post-survey. And then how would you rate your proficiency to provide a medical home for children with autism? And that was pre-survey, all the way down to not familiar, no proficiency. And this is post-survey. So we really feel like we've made an impact. And the other nice thing that I would say is monthly, we're still having continuing case-based webinars with the graduates of our first 2 cohorts. So I think people are becoming even more comfortable. This I just want to pull up. This is from the National Center for Medical Home Implementation website. I am very proud to announce that one of our graduates from the first cohort, Dr. Clarissa Smith from Prescott Valley, is now certified to be a medical home. And she is one of our shining stars. She's one of the first pediatricians to complete all the reliability testing for the STAT tool and then reliability testing for an autism diagnosis. So what they do is once they've learned the STAT tool, once they've finished the 6 months collaborative learning, once they've done their QI projects, then they go through 2 levels of reliability testing with Vanderbilt, the creator of the STAT. And then once they see those kids and they've done the Vanderbilt, they've done the DSM criteria, the child has had ADOS testing by another person that supports the pediatrician's diagnosis, they send all that to me. And then if they're outside of Maricopa County, I do a telemedicine consult. If they're inside Maricopa County, they come to the office for me to do a confirmation diagnosis. And we are doing 3 of those. And then after that, we're telling DDD, these people are reliable to diagnose autism. And a perfect example of what's happened is for the first 10 children that failed the M.Chat or had concerns on the M.Chat that Dr. Smith saw, only 4 had a diagnosis of autism.
So what does that mean? That means that those 10 kids could have all been referred to DDD for at-risk for autism, but only 4 of them really needs DDD or other or insurance coverage for autism therapies. The other 6 don't have autism. And so those other 6 she knows what to do with. One's just in special needs preschool, one needed a hearing test and has hearing loss, one has been in and out of foster care and needed behavioral health, so she knows what to do with those kids. And those are 10 kids that I never have to see. And if she has concerns, she calls me up and we talk about it. And so, and at this point she's at 16 because some of the other practices in Prescott Valley are now referring to her for a consultation. And so it's a beautiful thing. I mean, if we're hoping to train between 42 and 46 of these pediatricians. We'll know more after November 16th and our 3rd cohort starts. But that means if in a year, if they see 30 kids times 45, that those are all those kids that don't need to be referred to Phoenix Children's. And Dr. Kessler retired. So in Phoenix, there's Dr. Melmed's group, and then there's us at Phoenix Children's. Myself, Dr. Ruggiero works with us 2 days a week, and then I have 4 fabulous nurse practitioners. Well, Dr. Melmed doesn't take access, right? And so that's a problem because we have over 3,000 kids on our waiting list. I don't want those kids waiting to be seen for an autism diagnosis or any other diagnosis they might have. So this is what graduates are saying. I feel that I now have the tools to organize the evaluation of children with developmental delays and shorten the time it takes to them to receive a diagnosis or meaningful intervention. Familiarity with the M.Ed and the STAT have really helped me understand what autism looks like. I feel more confident in identifying at-risk behaviors even when parents don't report them. And to be able to provide this service in our community will set a precedent for the future development of an organized developmental program for all children. So I want to tell you about another just great example. Dr. Sorensen, who's in Maricopa, took part in cohort 1 or cohort 2?
1.
1. So I work at the Indian Medical Center, the Phoenix Indian Medical Center, every Thursday. I got a referral for a 29-month-old who lived near Maricopa, not Maricopa County, the town of Maricopa, in March 2016. My next available new patient appointment is March 2017 at PIMC. So this 29-month-old would have to wait a year to get an assessment with me. But I called up Dawn Sorensen and I said, hey, do you take IHS Access? Can you see this kid? And she said yes. She saw this kid, the referral was in March. I talked to her, she got it scheduled for May or June because she had to finish her reliability testing. She saw the kid in June, the kid had I think the child had an ADAS maybe in May. She saw the child in June, finished the assessment, diagnosed the child with autism, got them into resources. The child started in intervention in July. It's a lot better than waiting a year to see me to start intervention, right? And so that's what we hope to continue to accomplish. And so with early access to care, we really hope to provide this innovative, community-based, integrated identification, screening, and treatment model with our regional teams. We're supporting pediatricians, providing them with training and support. We're assessing their readiness for medical home provision and the telemedicine subspecialty support network. And I'm going to hand it over to Diana.
I'm going to make it really quick because I know that we're short on time, but one of the models right now that we have currently by one of our funders, TRICARE, if you take TRICARE, is that with TRICARE to get into the autism demo, the primary care physician can give the diagnosis, and what they're requiring is confirmation within a year. So that's extremely important for us to start thinking about because we are going to start seeing kids who may have a diagnosis from a pediatrician, who we might be able to get into services earlier. They may not have a diagnosis, but because the pediatrician referred them, we are able to start services earlier. We suspect that many of the other funders are going to start doing the same thing. And one of the requirements that TRICARE has to fit that model of the medical home is that in order for us to continue services after the first 6 months, is that we have to submit all of our paperwork back to that primary care physician. And so the idea behind training these primary care physicians is, again, to make them the hub of the services. So one of the things that we have to do with these PCPs, in addition to making them comfortable with diagnosing autism, we have to make them comfortable with the treatment of ongoing. So while this population has been around newly, early diagnosed children, we are carrying on the project to look at individual children who have a diagnosis but have comorbid or coexisting medical conditions that then require more frequent visits to the doctor. What type of support does that pediatric practice need? They need support around the waiting room. They need support around what to do when certain behaviors occur. They need support around how to take the blood pressure of a child with autism. So these are all areas that us as behavior analysts can start to think about in terms of this integration into a medical home. It's not just about the treatment in the home and community anymore, but it's also the treatment in collaboration with these primary care physicians. And then the other part of the project that we're working on right now is the telehealth delivery of ABA for family-mediated interventions. And I know for time, you guys can get access to the slides. But right now, we're looking at all of the access right now, or the availability that we have to start looking at research for ABA being transitioned to the families via telehealth and families implementing treatment so that there's more access to care.
Right, I just wanted to say a quick thing about this for anybody who's interested in the cost. So with regards to this first study by Scott Lindgren and his group, it's on functional communication training. And so I just found it fascinating. It was just to change one behavior, and they compared a therapist working with the parents twice a week, a therapist working with the parents via teleclinic, so the parents went to the clinic to get tele-coaching, and then the therapist coaching the parents in the home or telehome. And the behavior was trained, and then 6 months later stayed changed. Across the 3 study groups, it was the same. There was no difference, in-person teleclinic versus telehealth. And the in-person took an average of 17 weeks to be effective, while the teleclinic and telehealth parent-mediated intervention took 9 weeks. I don't know why that is. I find that fascinating. The cost of the average cost of the home therapy was $6,000. The average cost of the teleclinic was about $1,700, and the average cost of the telehome was about $1,100. So it is cost saving to provide access to parent-mediated intervention in the parent's home, and it has the same efficacy. So we're looking at, and we're looking for funding and talking to the state about Project Impact, which again you can read about on the websites, the PLAY project, the Early Start Denver model, which is not really possible because it takes 20 hours a week for 2 years of an in-person thing, but the PLAY project and Project Impact and Amy Weatherby's ESI is a lot less time of the therapists. So.
And we're out of town.
I know, we did 2 hours.